Hi, everybody. Welcome to the Neurocritical Care Society podcast. This is your host, Dr. Nicholas Morris from the University of Maryland and Shock Trauma Hospital. And today, as part of our Hot Topics series, I'm really excited to talk about the OXY-TC study, a study that was published in Lancet Neurology in November of this past year, which is really the first large trial of intracranial oxygenation, brain tissue oxygenation monitoring to come our way, with several more pending. I'm really lucky here today to have Dr. Tobias Gauss with us. He's one of the main authors on the study, and he is coming to us from all the way from France, so we're dealing with a little time difference, but we're so happy to have him on the podcast. Dr. Gauss, thanks so much for joining us.
Thank you for the invitation. It's a great honor.
Well, let's jump kind of right to the study, if you will. Tell us a little bit about the inspiration for the OXY-TC study and why this was a study really worth doing.
So the study has been initiated by Professor Jean-François Payen, who happens to be my boss. He's a great boss, by the way, and he apologizes for not being there today. So he was initiated back in 2013 because he was really convinced about the benefits of oxygenation optimization in traumatic brain injury, based on the then available observational data. And as we all know, the main therapeutic objective in traumatic brain injuries is to reduce secondary injury. And it's been, I think, a dogma for some while that improving oxygenation within the bundle of secondary injury prevention would be really a pillar of treatment, of critical care treatment of traumatic brain injured patients.
Great. And so, as you said, the study was actually initiated quite a while ago. Is it 2013? Is that correct?
Yes, 2013. Exactly.
And
that's when you started to obtain funding.
Great. And you were all, if I'm correct, you were enrolling at the same time as Boost 2, which has since been published. Is that also correct?
Yes, absolutely. And
Yes.
if I'm not mistaken, Boost 2 was published in 2017.
Yes.
So there was an overlap between Boost 2 and OXY-TC, which is quite interesting because when we compare Boost 2, when we compare the knowledge base of both studies back then, it was actually quite similar, and definitely within the last 10 years, our knowledge base has changed considerably, and probably some things that were conceived back then when the study was initially drafted, we would do it maybe slightly different now.
Oh, great. Well, I'd love to get into that later in the podcast. So let's describe the trial now. So this was a multi-site, open-label, randomized superiority trial at 25 referral centers in France.
That is correct.
Can you tell us a little bit about the inclusion and exclusion criteria for the study?
So since the ambition to be a pragmatic trial, the inclusion criteria were really based on a mixture of pre-hospital and admission GCS and the need for intracranial pressure monitoring based on the summary assumption of the receiving team. So that was the inclusion criterion. So very pragmatic. And sorry, what was your second question?
And some of the exclusion criteria.
And the exclusion criteria, they were again very pragmatic. So mainly to include very severe patients, so patients that would not survive the initial phase, and that were so heavily injured or had a injury burden that they would have a low probability to survive less than 24 hours. Post-traumatic cardiac arrest, neuropsychiatric comorbidities that would interfere with the outcome assessment 6 months and 12 months, ischemic stroke after the due, for example, to carotid artery dissection, participation ongoing trial as normal, and I think from a pragmatic point of view, low GCS of 3 with bilateral fixed pupils and penetrating TBI. These were the main exclusion criteria.
Great. So I think one important point there, just to point out to the listeners, is that patients with non-reactive pupils were allowed in the study, but not if their GCS was 3. And so I think there were, if I remember in the results, a substantial number of patients with bilaterally non-reactive pupils, but that's because their GCS must have been greater than 3.
Yes, that's a fair point. So their GCS was higher than 3. And you refer to one of the tables indicating the pupil reactivity. And the pupil reactivity is still part of the impact score. But as we all know, how it's also very fragile or subjective criterion. So, but definitely, there were patients where the clinicians initially thought they would have unreactive pupils, but it was unilateral. But if there was a low GCS, lower of 3, and bilateral fixed pupils, this would have been an exclusion criterion.
Well, great. And then can you tell us a little bit about the intervention? So it was sort of, as I see it, there was 2 parts of the intervention. So the patients were randomized either to an ICP monitor only or an ICP monitor plus a monitor of brain tissue oxygenation. Is that correct?
That is correct, yes.
Yeah. And that's somewhat different, I think, right, than what's happening with the BOOST study in that, so we don't really know what's going on with the brain oxygenation of the patients who are not going to be managed according to brain oxygenation.
That is a difference with the BOOST study, and slightly different also to the Bonanza trial. But so this has probably several reasons. So for one reason is that, if I'm not mistaken, in the BOOST trial, patients will receive 2 probes. Is that also because of the blinding? Whereas we only weren't allowed to insert an ICP probe and a TPO2 probe. We're not allowed to have a blinded insertion because of regulation issues, because of patient safety issues. So this was there was an ethical or safety issue here. And the second, but that's definitely a point of discussion, is when actually which are the patients that will benefit from oxygenation optimization, and should you do this for all kinds of patients very early? And so no matter how severe they are, you start this from the start because you think that the benefit is, no matter how severe the traumatic brain injury is, how high their ICP levels are, or do you wait a little bit and you only target this intervention for the most severely injured patients? And that is a very interesting question.
Yeah. Can you tell us, in the OXY-TC study, when did these monitors go in?
These monitors were allowed to go in up to 12 hours, but the mean time of insertion was actually 6 to 7 hours. So they went in
quite early.
Yeah, they went in quite early, yes.
That's great. And how long did they stay in for?
They stayed for 5 days.
Stayed for 5 days. Were there any exceptions to that? If clinicians were using the monitors, did they continue to use them if they felt that they were functioning and important?
Absolutely. So they were allowed to use them beyond the 5 days, but 5 days was the observation window that was for the trial. So optimization was performed within this 5-day window.
Great. And then, similar, it seems like, to other studies that are looking at brain tissue oxygenation and TBI, the idea here was to sort of come up with some type of treatment protocol for patients based on what was happening with their ICP and what was happening with their brain tissue oxygenation. Can you take us through the different sort of categories of abnormalities and how those were managed in the study?
Of course. So again, because of the ambition was to have a pragmatic trial. So within the control group, patients were, the ICP was supposed to be controlled with a 3-tier level strategy that corresponds to the Seattle consensus or to the international recommendations, meaning that this would include normal strategies of baseline management of any TBI patients. And tier 2 treatment were introduced then when the intracranial pressure exceeded 20 20 millimeters of mercury with deep sedation, analgesia, vasopressor, optimization of cerebral perfusion, moderate hypoventilation, bolus osmotherapy. And then if the ICP was still raised, they were then treated according to tier 3. That included, for example, decompressive craniectomy or barbiturate coma. The same 3-tier strategies were applied to the interventional group, but with the additional obligation of the team to keep the PTO2 above 20 millimeters of mercury at all times. So they had there's a very detailed protocol that is accessible in the supplementary files, and I think one of the strengths of the study is that the teams in all centers really have very high adhesion, very high compliance with the guidelines of the study trial, the protocol.
That's fantastic. When I was looking through that detailed protocol, I was having trouble finding, was there a specific time period for which an intervention was meant to be given if either the ICP was above 20 or the PBTO2 was less than 20?
No, that is true. That is a fair point. From my memory, there was no time, there was no delay given, but it was supposed to be as quick as possible.
Okay.
There was supposed to be no delay.
But it seems like we don't actually know perhaps when the interventions were given, the timing of the interventions.
Yeah, that is a fair point.
Okay. Well, fantastic. And what was the primary outcome of the study?
The primary outcome was the Glasgow Outcome Scale at 6 months. So the idea was to reduce the proportion of patients with severe disability or death at 6 months.
Very, very standard outcome for traumatic brain injury studies. And I think similarly, I think the same outcome that will be the primary outcome for both Bonanza and Boost 3.
That is true.
Hopefully it will lend itself well, perhaps, to meta-analyses in the future or being able to share data.
That's something that we really would be very, very happy to do, to pool the data and probably this. But maybe to reflect a question back to you, what do you think is that, because this is sort of an intuition or a second thought I'm having about the study is, do you think that 6 months is actually too early and that we should probably wait for much longer, but then we risk losing patients to follow up?
Well, that was one of my questions for you, so you stole my thunder. I think it's an interesting time right now where we're learning that recovery continues well past 6 months and even to a year. I think it would be interesting to look at the trajectories out at least to 12 months and see. I don't know, was there any planned follow-up at 12 months for the OXY-TC study?
So we have the outcome at 12 months. We actually followed them up to 12 months. So it was one of the secondary outcomes.
Yeah.
But also with the results from the patch trial on tranexamic acid, probably we have to move there, but this will generate an additional burden in terms of funding and follow-up for these kind of trials.
Absolutely. I wanted to ask you a question. I read with interest in the manuscript that initially the primary outcome was actually supposed to be something different. Can you talk a little bit about that and why the change was made?
Yes, so that's a very good question. So the initial outcome was an MRI quantification of brain injury volume between day 6 and day 10 after the injury. And to be very honest, this was very difficult to perform and to obtain for feasibility reasons in several of the participating centers, and also the investigators felt that this was probably an outcome that had less of a clinical and was less patient-centered than the Glasgow Outcome Scale. So this is why the primary outcome was then amended in 2018 to become the Glasgow Outcome Scale.
Got it. Well, I'm hopeful that at some point we'll get a report on those patients that did have MRIs, and we'll maybe perhaps learn something from that analysis.
So this is a paper we're currently working on. Yes, there will be a subsample of those patients.
Great. Well, we'll look forward to that with interest. What were some of the other major secondary outcomes that you all were interested in?
So secondary outcomes were patients at 12 months, as I mentioned, the goals at 12 months. And then the different ratios at different time points, also disability rating, quality of life, therapeutic intensity level, according to the TILSUM in the first 5 days. And I think an important secondary outcome were critical events in both groups.
And would you mind summarizing the major findings from the study?
In terms of secondary outcome, yeah, of course.
Or in terms of primary outcome, I guess we should start with, just to be clear, and then.
So in terms of primary outcome, there was no difference in the primary outcome between the two groups. So they had the same proportion of patients with an extended Glasgow Outcome Scale at 6 and then secondary at 12 months. There was no difference at 6 and 12 months in terms of disability rating, nor in quality of life, or nor in therapeutic intensity levels, with some signals, but nothing major. What was really different was the incidence of critical events between the two groups, with higher incidence of hematomas in the intervention group.
Yeah, I was interested to read that. Great. I think that's a really wonderful summary of the main findings. There was this really interesting post hoc analysis that I think has gotten some attention when you looked specifically in the patients with initially high elevated intracranial pressure greater than 20. You found something different. Can you tell us what that was?
Yeah, because we were surprised, or we were, of course, not disappointed, maybe a bit strong, but we were hoping for a different result. And so we then performed, as you said, some post hoc analysis in terms of injury load, in terms of injury type, oxygenation, and in particular in terms of intracranial pressure. And there seems to be a tendency, but it's only post hoc analysis. There's a tendency of a better outcome towards better Glasgow Outcome Scales proportion at 6 months in patients with raised ICP. So this could invite indeed for some new studies to target the intervention for really severe TBI patients and start with patients that have a raised ICP very early in their trajectory. And from my knowledge, unfortunately, neither Bonanza nor the Boost 3 trial target patients with raised ICP from the start.
I believe that is correct, yes. Great. Well, digging a little bit further into the results, there's some that I think were really interesting, and maybe we could talk a little bit more about them. So I noted that almost 75, I think 74% of patients that had PbTO2 monitoring received at least one treatment for brain hypoxia. So brain hypoxia was quite common in the cohort overall. And then up to 30% had episodes of what you all defined as critical brain hypoxia, which was PbTO2 less than 10 for greater than 30 minutes. Was that around what you expected?
No, that was surprising, actually. That was surprising. And that was especially surprising since it was performed in all expert centers. So I think that's a very, very exciting way forward for future studies to dive into that.
Yeah, I had to go back and I looked at Boost 2, which of course was just a phase 2 study, a bit smaller in scale, but in that study, sort of this critical brain hypoxia, which they defined slightly different. They used a PbTO2 of less than 15 for 30 minutes, but it was 16%. So interesting that somehow these cohorts might be a little bit different, and maybe I'm not sure why that is. I think that's something that we can only hypothesize about. But do you have any ideas about why maybe you saw more critical hypoxia than they did in the Boost 2 trial?
No, honestly, I we have no explanation that is really satisfying. And 10 and 16% could still be, when we talk about the numbers, could still also be just a variation of the observation. So
Yes. Yep.
this is why it will be very, very interesting to see the data from the Bonanza and Boost trial, and to pool them and to see whether there is a signal. The same applies to the type of TBI. So of course, there's a lot of discussion about the heterogeneity of TBI and the type of injury, and so unfortunately, we didn't have enough data to look into this. But maybe pooling the data from three randomized control trials could at least indicate us where to go. So we are currently following two avenues. Is one, what we try to do with a large observational sample is to create, actually, to see what kind of phenotypes we can identify in terms of injury patterns. And the second avenue that we follow is use some sort of machine learning or segmentation of the admission CT scan to try and standardize treatment groups, because this is definitely also some of the, a critique is that you could say that maybe there was some level of heterogeneity. But again, this is also a force of the trial, because it's still very pragmatic. This is the kind of patients that you receive and that you will have on your neurocritical ICU.
Yeah, I agree with you. I think it's actually a strength of the trial. I think if the trial is too prescriptive in this very small, narrow window of patients in which it provides evidence, it limits the generalizability in ways we might like to use it. I wanted to talk a little bit about some of these, as you brought up Bonanza and Boost, and some important maybe differences in the trials. One thing that struck me when I was sort of comparing the protocols for the trials is actually the size of the cohorts they're looking to enroll versus what you enrolled, and I think that goes a little bit towards their power analysis and what they were hoping to show. On my review, I think it's always amazing to me how small changes in the power analysis lead to giant increases in the necessary size of the cohort to run a study. So I think I'm trying to review here, but it looked to me like they are enrolling maybe up to over 800 patients in each one of those studies, whereas your numbers, if I'm correct, were somewhat lower than that. Is that correct?
Yes, much lower.
Yeah.
Small but beautiful.
And so I think it's a really good point that you brought up about the length of follow-up and the cost associated with these trials. I'm sure cost was a major factor in designing the trial, and how that plays into having a protocol that's feasible to complete. I'm not sure if you can have any insight to offer about that, but we'd love to hear
I think this is such a good question, seriously, because it highlights the challenge to perform such a complex trial, and the question in which is the best setting to perform this trial. So Bonanza will be an international multi-center trial, and we will be one of the participating centers in Europe. So we're very lucky and very happy. But it shows that even the ANZIC, the very powerful ANZIC network, requires partners, international partners, which will, of course, then increase the external validity also of the trials, but it's a big strength. US, I mean, the US is the US in itself is a continent, so you have the number of centers and recruiting capacity and financing to pull this through. But what is also interesting, and we really should, as a research community, ask questions, is the pipeline. I mean, we spoke with Professor Payan. He initiated this trial in 2013, and we published the data 10 years later. If I'm not mistaken, Boost, they started including in 2019, and they expect to finish in 2027. So probably then have results in 28 or 29. So it's also a 10-year. So that the pipeline is really challenging for everybody, no matter the system they perform and they conceive the study in. But in this time, lots of things happened, like new knowledge base, so this is something that we as a research community, an international research community, we have to find a way to accelerate this pipeline, I think. And then you mentioned the power analysis. That is, of course, crucial because it all starts with the hypothesis, the baseline. So we expected about 50% favorable and unfavorable outcome based on the available data then. And actually, this has been quite confirmed by recent evidence. It's more or less the same in Boost and Bonanza, but they go for 10% change, whereas we expect a 30% change. So here, of course, you get different sample sizes. But there's and this is where I think our trial provides an interesting message, is that there should be a balance between the risks of a very complex intervention. And when you look at the incidence of hematoma in the interventional group, that outweighs the benefit. And if your benefit is only 10% of improvement in GOES versus some percentage of complications that will probably increase if you roll this out to more patients or also in maybe less expert centers, because we saw a learning curve in the placement of the probes, even in expert centers, then you can actually, the question is, what is the right balance of improvement that you expect and the sample sizes that you will need?
Right. Absolutely. And I think just to be clear in my reading, so I think you were looking for a 30% relative reduction, which would lead to a 17% absolute reduction.
Exactly.
And in the Boost 3 analysis, they were targeting a 10% absolute reduction. So maybe 17 versus 10% is what we're talking here. And yet that brought the sample size up from
350
to 880.
800, yes.
Almost 900. So really, really incredible different number of patients based on these small changes in calculations. One other difference that I noticed in the trial protocols, in the Boost trial, as we're one of the sites here at University of Maryland, there is this time pressure to act. But one of the other things that the study does is it doesn't really prescribe the order of interventions within a tier. And yet I noted that in your brain hypoxia algorithm, there actually is an order to your interventions. And that really started with increasing the PaO2 through changing the ventilator settings. Can you talk about that decision on how to organize your tiers, and do you continue that practice now if you're using monitors?
Yes, this is actually, and we had a discussion this afternoon with Professor Payen. We were a bit, we were happy because it reflected our practice then, and of course improved, and we learned things, and it continues to be our practice now. And this is why also this is one of the strengths, as I mentioned earlier, is that all the clinicians, they actually stuck to the different levels, to the tiers, and they didn't escalate unless they had really exploited all the means that were available in the respective tier to improve pressure, oxygenation, and perfusion. And I think this is an important aspect, that you should not jump too early to very escalating therapies.
Agreed. Yeah, I thought one of the interesting things about your algorithm is one, it's very easy to interpret, which is nice. I feel like I know exactly what you all did during the trial and what the centers did, whereas I'm not sure we'll know that exactly from the Boost data, because you can sort of pick a couple different interventions from a tier and then move on, and there's no clear ordering of the tiers. But on the other hand, as a center where sometimes we're using Lycox monitoring with also microdialysis numbers, sometimes we do see that improvements in the PbTO2 that are generated mostly from increases in the PaO2. Sometimes they don't actually improve metabolic crisis, and sometimes perfusion-oriented measures seem to have a greater effect. So I was just wondering, in your practice, after these results have come, has there been talk of of changing the ordering of how you may deal with brain hypoxia?
That's a very good question. So interestingly, no, it has actually more been of a pragmatic confirmation. It really confirmed, gave us the real, a very positive feedback on what we do on a daily basis. And I think that also maybe it reflects sort of the French school of thought. I'm not saying that this is superior to other school of thoughts, but since there's a tight-knit community, this maybe also explain that across the different centers, people really stuck to the protocol, and which is important in such a complex trial, because if you have interventions all over the place and people jumping between the tiers, and so this makes a trial very difficult to interpret, and you create a lot of confounding variables that are difficult to control.
Great. Well, I want to congratulate you and the other authors on completing this trial. I think it's so informative, and it's such an important study. You mentioned as we started to talk that you feel like maybe you did learn some lessons along the way, and maybe if you were to do it again, you would do things differently. I'm wondering what were some of those lessons, and what things would you like to maybe have tried differently?
That's a good question. Can I call my lawyer? I asked Jean-François the same question. So we probably would change the inclusion criterion, because there's always a discussion, and I think it was actually also mentioned in one of the editorial that in the Lancet Neurology, is if you have GCS, we all know how the GCS can be fragile, and even if you associate it with some injury measure or some intervention, so probably there could be a discussion about the inclusion to make them more robust. I don't think that there was an ascertainment bias, but this is definitely a thing that should be thought about. And maybe we will have, it's what I mentioned also, the artificial intelligence could be that maybe, but this is very, very early, and I think it's much too early, but this could maybe sort of stratify and make some inclusion criteria more robust. But the challenge needs to be pragmatic, because we want to perform the intervention early. And if you, as you mentioned yourself, if you segment and stratify in too many different things, then the external validity will be hampered. So yeah, so the inclusion criterion, I think that the tier process was really nicely done. From a methodological point of view, maybe it would be great to have a single probe that has PTPO2 and ICP in one single probe, and then you can have a proper masking of the intervention, also for the clinicians, instead of inserting two probes, which increases or raises some safety issues. To have a single probe that integrates both signals, that would be great.
Great. I wondered as well if just by unmasking things, if there were some unmeasured confounders perhaps in the way that clinicians responded to treatment patients or not. I think we'll never know the answer to that. Well, that's all very interesting. I think thank you for sharing those lessons. I guess one other thing that I wanted to get your opinion on, I think you had mentioned that there were maybe some trends in the therapeutic intensity levels but they weren't very significant. But I did notice in some of the supplementary data, the two groups did seem to change a little bit in the therapeutic intensity level on days 4 and 5. And I think Boost 3 is also using 5 days as their time window. But any thoughts about extending the window and longer? Maybe something there? I'm not sure.
Again, it's an excellent question, because you could say, why 5 days? Why not? Why? I mean, some of these patients, they are in raised ICP for 2 weeks. So why only 5 days? Again, we run here into feasibility challenges. in a large complex trial. We actually collected like tons of data that we have not been through yet, and like really hourly, some data hourly, Dopplers, and so we have to go through this. And our research assistants, they're really they're pulling their hairs out because it's so much data. Maybe again, without being too optimistic, but maybe if we had tools, and we will have, I mean, they're available, but if we have sort of automatic, like an automatic data extraction from clinical software, bedside software, and associated also with some autoregulation indicators, maybe this could facilitate to prolong the observation window, so that to reduce the workload and allow for improved feasibility of this kind of long observation, and really have an international consensus on what do we want to look at for 10 days, 15 days, 3 weeks. Because currently we're still in an exploratory phase, and there's a balance between feasibility and workload, and what should be really meaningful indicators to follow.
Great. As we wrap up, have you changed your clinical practice based on the results of the study?
I can't say that here, at least in Grenoble, we have really changed our practice. It really sort of confirmed what we did then, and we probably are slightly more aggressive with the very sick patients, those who present with high ICP early, and maybe more watchful for those who don't appear so critically sick. So probably this is a tendency.
Great. And I'm sure you all are already planning kind of the next steps in trying to improve care for these severely injured, brain injured patients. Where do we go from here? And that's a $1 million question, right? But
again, I will only speak in the presence of my lawyer. As I mentioned earlier, so we have 2 studies running where we definitely try to use segmentation methods with the initial CT scan to improve since we think there is to target those who will really benefit from very intense early intervention, and to try to have a more robust estimation of, and also the type of traumatic brain injury. So this is a study that I coordinate, is trying to bring together clinical indicators based on machine learning tools, and associate this with a segmentation of the admission CT scan to really identify early on the patients that we would really target with a very aggressive strategy from the start, and not sort of sometimes wait 24, 48 hours to lose a maybe very beneficial and precious window.
Great. And then this my final question will wrap up. To use your own language, we thought that avoiding brain hypoxia was a pillar of neurocritical care in traumatic brain injury in particular. Do you still feel the same way? And if not, why?
I still feel the same way, and as much as the OXY-TC trial is really the first important step, I think it's just a step on a journey. And if I compare it to what we've been learning in trauma, for example, over the last 10 years, if I compare it to the bleeding patient, and that really pushing the community to perform rigorous randomized controlled trials to challenge dogma is the best way to go. And there's probably not a single trial that will provide all the answers, but it's a learning, it's step by step, learning step by step, and build on randomized trials on each other, so that It's probably not definitely, I still believe in it, and we still have to recommend it, but the journey is not yet over. And I can't tell you what I would say in 10 years' time, in particular, once we have Bonanza and the Boost trial.
Great. Well, thank you so much. And congratulations again on really a wonderful study, and to you and all the investigators. I think we've learned so much from this. And as you said, perhaps this is just the first step of many towards really understanding how to monitor the brain beyond ICP and to respond appropriately. So on that, we'll wrap it up. My name is Nick Morris. This is the Neurocritical Care Society podcast. It's available anywhere you get your podcasts, and continuing medical education credits are available for select episodes. Thanks so much for joining us. Take care.